Welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for joining us for another segment. We're going to be speaking with Dr. Campbell Rogers. He's joining us here to talk about the current state of heart disease. It's the leading cause of death in the world. According to the CDC, over 650,000 people just in the United States die every year as a result of cardiovascular disease. He's joining us here as Executive Vice President and Chief Medical Officer at HeartFlow to talk about some of the latest developments in cardiovascular care. Welcome to Health Professional Radio, Dr. Campbell Rogers.
Thank you. It's a great pleasure to be here, and I appreciate your having me.
Well, obviously, you're a cardiologist. Give us a bit of your professional background and talk about your role briefly at HeartFlow.
Sure, happy to, of course. My background is as a cardiologist, as you mentioned. I practiced for many years as an interventional cardiologist at Brigham and Women's Hospital in Boston. Interventional cardiology, for those who may not be familiar, is taking care of patients through invasive procedures, diagnosing coronary disease, putting in stents to correct blockages and things like that.
Mm-hmm. Heart disease is the leading cause of death in the world. It almost seems as though we're all destined to have some type of cardiovascular condition if we live long enough. Is that the case?
I think for many, certainly not all, but for many, it's incredibly prevalent in our population. Again, many patients have coronary disease and are asymptomatic from it and die with it, not of it. But there are many, of course, who do die from cardiovascular disease and coronary disease particularly. And there are, many, many more who suffer symptoms from it, even if they don't die from it, and are limited in their activities and their quality of life, et cetera, because they're suffering from symptoms of coronary disease.
Now, coronary cardiovascular disease, it's a kind of a coverall. There are several different types of diseases that fall under cardiovascular disease, several different types of conditions, right?
Yes, there are. Cardiovascular disease as a whole relates to diseases in the overall system of pumping blood and bringing blood to all different parts of our bodies. So it can manifest itself, for example, in the brain as a stroke, or in the lower extremities as pain when walking in the leg muscles. The most common cause of death, and one of the most common forms of the disease, is coronary disease, and the coronaries being the arteries that bring blood to the heart. And when they become narrowed with atherosclerosis, or what's commonly known as hardening of the arteries, they cause symptoms of chest pain, and then can go on and progress to causing patients to have heart attacks.
What would you say is the most important aspect of cardiovascular disease? Is it genetic? Is it environmental? What would you say?
That's a very good question. It's both. I'm going to dodge answering your specific question because it really is both. There are clear risk factors that include family history, that include environmental exposures, that include things like cigarette smoking, that include diabetes, high blood pressure. So it's multifactorial. But suffice it to say, there are certainly some things that one cannot change that puts one at risk for cardiovascular disease. And there are some things that one can change, be it quitting smoking, managing diabetes rigorously, and things like that.
Now, as far as treatment strategies, obviously identifying the condition early is imperative. As in any disease, the earlier you identify it, the greater your treatment options seem to be. What normally is the go-to for, I guess, the biggest cardiovascular disease? What's been the traditional treatment?
Yeah, so let's talk about diagnosis first and then treatment. So diagnosis really falls into two categories. One is identifying patients who may be at risk for developing coronary disease. And let's talk about coronary disease specifically. So, for example, patients whose cholesterol may be high and may be at risk for developing, and there the diagnosis is, of course, measuring lipid levels and then assigning primary prevention treatment. Primary prevention being treating before the disease actually takes hold. And that may be modifying diet, taking drugs to lower cholesterol, and so forth. The second category, though, is patients who are developing symptoms of having coronary disease. So maybe people are having chest pain when they exert themselves. And that's really a harbinger of what may be important to coronary disease, and there are other diagnostic pathways for that. The challenge is that second group, there are many other ailments which can feel the same to a patient. So teasing out, is this patient's chest pain related to their heart, whereas in other patients may be related to something completely unrelated to the heart, has proven difficult. Over the years, stress testing has been used, and there are various forms of stress testing, but stress testing has been used to help determine whether patients' chest pain symptoms are in fact related to their heart. And this has been the go-to for decades. Stress testing can include both actually having somebody walk on a treadmill so their heart goes through the stress of exercise, or administering drugs, which in many ways mimic exercise. And then during that period, looking at the patient's heart function by giving them radioactive dyes, which can locate to different regions of the heart by looking with echocardiography or electrocardiography at the heart. All of those have been the go-to for decades. The challenge with that has been that those tests are increasingly being proven to be inaccurate and inadequate by both under and over diagnosing disease, missing patients who actually have important coronary disease but are falsely reassured by a, quote, normal stress test, and then diagnosing patients who, quote, fail their stress test and then are gone on to other testing, often invasive testing, only to have that invasive testing reveal, good news, the stress test was a false positive, but to get there, we had to go through this invasive pathway.
Now, HeartFlow's developed a product, the HeartFlow FFRCT analysis. Talk about this development and how it's going to help physicians better diagnose and better treat cardiovascular disease by detecting it early and offering better treatment options.
Yeah, so there is a new pathway, I would say an ascendant pathway for diagnosing coronary disease in patients with symptoms, which is taking hold around the world. And that is the pathway as follows. It starts with not a stress test, but rather a coronary CT angiogram, which is a non-invasive test, takes just a few minutes, and shows pictures of the arteries to the heart. Actually shows the arteries, it's not an indirect measure, and sees whether there are narrowings. When there are narrowings, HeartFlow is able to then provide measurements of blood flow in that exact patient's heart in a patient-specific fashion to then inform the physician, are these narrowings in this patient at this point in time actually importantly lowering blood flow to the heart? Or is this a patient who has these blockages, but this can be managed in a conservative way because at this point in time, they're really not compromising blood flow to the heart? This new pathway I mentioned is ascendant. It now is reflected in practice guidelines, really increasingly around the world, including very recently in the U.S., where the American College of Cardiology and the American Heart Association have recommended this pathway in their most recent update of the so-called chest pain guidelines, which just came out in the last week or two.
Well, give us a website where we can learn more about HeartFlow and about this personalized 3D model of patients' hearts that enables physicians to diagnose heart disease and treat it more efficiently.
Yeah, so the place to start would be at heartflow.com. There we have, for those interested in the details, both visual representations of what we provide to physicians, but also references, a list of references to some of the most important clinical studies. We now have over 500 publications in the medical literature, peer-reviewed publications, and many of the most important are also linked to on our website, so people may find that helpful as well.
Well, Dr. Rogers, I appreciate you spending this short period of time with us on the program this morning, and I'm looking forward to another conversation with you in the future.
I look forward to it, and thank you.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Campbell Rogers. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download it, SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.